Great. Okay, good evening, everybody. It's a pleasure to have you all here at this wonderful event, the launch of Beth Mills's book, HIV, Gender and the Politics of Medicine. Wonderful to have such a large audience, and we also have a lot of people online, so I'm hoping we're going to have a very interesting and stimulating discussion and a celebration of the achievement of the book today. I'm Hayley MacGregor. I'm a Professorial Fellow in the Health and Nutrition Cluster at IDS. I'm the chair today, and I'll give you a brief idea quickly of how we are going to run this event, and then we'll go straight in. So Beth's a senior lecturer in international development and anthropology and global studies at Sussex. And I've actually known Beth for many years now. We first met when she was working at the AIDS and Society Research Unit at UCT, the University of Cape Town. And then she came to do a PhD here at IDS with Melissa Leach and myself. I can't even remember what year that was back.
It's 2009.
Oh, yeah. Yes, okay, I was going to say 2006, 2009. And so it feels particularly apt. Beth was a PhD student here. She then was a research fellow at IDS before going to Sussex. So it's really wonderful to welcome you home to IDS for the book launch. And I should say this is joined with IDS, but also with CORTH, the Centre for Cultures of Reproduction, Technologies and Health, which is at the University of Sussex. And indeed, Maya is director of CORTH, and Beth and I are co-directors. So this is also a celebration of CORTH in that regard. So it's really a proud moment to launch this book because it covers such a span of 2 decades of research and activism around HIV medicines in South Africa, and now also beyond in Brazil and India. And we're hoping to cover that international span. So reflecting in preparation for this event, I was really struck by the timeliness of this book and the sort of empirical and theoretically rich scholarship on the politics of access to medicines across these scales, right from the local to this global view towards the end of the book around the politics of access and governance of that. And also the way in which precarity manifests in these particularly intense ways. And I've just flown back from South Africa, actually landed this morning, and it just feels particularly timely also in this kind of economic hardships post-COVID and these issues, and the embodiment of precarity as a theme of Beth's book feels as timely now as it was 20 years ago. And there's also the wonderful sort of gendered element and women's role in those struggles. And we're so pleased to have Nondumiso online to reflect that. And of course, these inequalities in access, they continue to play out. I'm quite involved at the moment in the MPOX response, and the same themes play out. And indeed, that learning and reflection from the HIV experience in South Africa and beyond is so relevant now as ever. So you're in for a treat. So first we're going to have a summary from Beth for about 10 to 15 minutes. She's going to take us through the span of research. And then we have 3 very eminent discussants. So we'll start with Nondumiso Hlwele, who is an activist, a member of the Bambanani women's group, also an artist, has a long collaboration with Beth, and we'll first have her reflections. We'll then come back into the room, and Nondumiso's online, we'll come back into the room, and Maya brings a long history of work on similar issues in India, the sort of reproduction and politics, reproductive justice, and Maya will offer some reflections, and then we'll go online again, and Lenore Manderson will offer her reflections. Maya's a professor of anthropology at Sussex, and Lenore at Wits, the University of the Witwatersrand in South Africa. And after that, we'll open it up to the floor, and we'll have hopefully about half an hour for discussion. So that's where we're going, and I'm going to hand over to Beth.
Wonderful. Hi, everyone. It's so wonderful to see so many people in the room. And hi, everyone online. Thank you so much for joining, everyone. Are we good? I have to remember I'm not a lecturer in this space. I kind of want you to like all talk to each other and introduce yourselves, but We'll get there. We'll get there. Hopefully in an hour's time, we can have a good conversation. I'm really looking forward to hearing all of your reflections. I want to start by thanking everybody who's on the panel for making the time to be here today. And thank you very much, Gary, for all your work and putting the event together. I also want to start by saying that Nondumiso, I'm so grateful you're here. I have dedicated my book to Nondumiso, along with Pumla, two very important people in my life, and without whom this book wouldn't have come to fruition. So I really want to acknowledge that. I also want to acknowledge all the people that I've worked with across 2 decades. And in fact, Mark Hayward is here, and I remember working with you many years ago. I'd like to acknowledge the work of the Bambanani Women's Group. I'd like to thank Solange Rocha and Anna Vera at the University of Pernambuco and the Treatment Action Campaign in South Africa. Hayley, MacGregor, and Melissa Leach were my supervisors, as Hayley has said. And you've both played a pivotal role in supporting me for a good part of the last few decades, even beyond that. And I continue to learn from you both. And Hayley, I wouldn't want to be doing this with anyone else. Okay, so with those acknowledgements that are really important and should be at the start of any talk about a 2 decades length of book, I'm going to move into telling you a little bit about what we're going to look at today. So, Gary, how do we get this into presentation mode? Small technical. Okay.
That was a moving slide.
I'm sorry. It's a little bit less moving than when I was using the different programs. This is Canva, which I love, and I really like the brightness. So I'm going to be covering very briefly 2 decades of work. I'm not going to do that justice by any stretch. So do bear with me. It's going to be a relatively short, succinct overview of what my book covers, some of the key arguments, and some of the kind of areas in which I've conducted my ethnography across this time. And do make notes of any questions you have as we'll go through this journey together for the next hour or so, and we can talk about them at the end. I want to start in the present with this photograph over here, taken in 2024 in Munich, so in July this year. And it is a picture of activists who are protesting Gilead. So Gilead is a pharmaceutical giant that has produced a medical miracle, one that I wouldn't have anticipated knowing about or thinking would be possible 20 years ago. It's a long-acting injectable that's available that if you use twice a year, you are supported in your management of HIV. And it's also been shown through 2 gold standard trials to be an effective treatment. Absolutely brilliant, groundbreaking medicine. And yet, at the time that I wrote my book, it was not available in any of the countries where Gilead had conducted its trials. Guess how much it costs to get 1 year's worth of this treatment if you live in the US? Any guesses? 50 grand? You're very close. It's 42,000. I guess how much it is possible to produce it for as a generic for 1 year. 2 grand? 2,000. $100. So this is the point of my book. Why are these life-changing essential medicines priced out of reach for most of the people in the world who need them? At the moment, we have a new HIV infection once every 24 seconds. Most of those infections are taking place in low and middle income countries. Most of those countries can't access this new drug. However, fear not, there are activists fighting this. We have the MSF's Access campaign that have been calling on Gilead to issue voluntary licenses. And we have HIV community organizations in India, Argentina, Thailand, and Vietnam who filed 8 oppositions against Gilead's lenacapavir patent application. And they've been successful. So just 2 weeks ago, On the 3rd of October, Gilead announced that it had signed a licensing agreement with 6 pharmaceutical companies to make and sell affordable generic lenacapavir in 120 high-incidence, resource-limited countries. I start with this case to really show how patents can escalate the price, how generics can reduce the cost and make it much more widely available, and also to show the power of activism in challenging and shaming pharmaceutical companies to make these medicines more available. This case, 2024, speaks to a much longer history that my book traces around medical developments, pharmaceutical monopolies, and the coalition of transnational activist organizations to compel governments to challenge pharmaceutical companies and even to change international patent legislation. My book traces part of this history as it unfolded in South Africa, Brazil, and India over 2 decades, from 2003 to 2023. In the introduction to my book, I acknowledge that starting places matter. And with reference to anthropologist Rebecca Marsland, who writes, if you start from the negative minimalisms of sheer survival and bare life, of violence, suffering, deprivation, and destitution, then you provide a very different description of lives than if you begin from people's situated concerns. Our tendency to focus on the dystopic has been at the price of forgetting to think about other ways of thinking. Supposedly, this is what anthropologists do best. So my book is situated at a time when we had started to have a rollout of antiretroviral treatment in South Africa. And what I wanted to explore is what happens when we have access to these hard-won medicines, when the struggle for access to those medicines shifts somewhat under the surface. And what we start to see is the impact of the turning tide of AIDS funding. We start to see the impact of chronic levels of unemployment and other forms of structural violence that are inherited through long, long centuries of colonialism and apartheid. So while I don't really start from a place of hope or even a place of despair, my book is situated somewhere in the middle. And it says we need to be situating people's everyday lived experiences of both medicine and of the politics of democracy in their voices and their experiences and their contexts. I'm going to give you a summary on this slide. Apologies for all the text. Of the 2 main arguments that I developed across the book, and as a spoiler alert, my final slide comes back to this and says, of course, these are connected. Of course, we need to be thinking about how medicine is embodied, and of course, we need to think about how medicine is political. In a recent talk on socio-technological imaginaries, Sheila Jasanoff, Professor of Science and Technology Studies at Harvard, refers to 2 destabilizing changes in the way that we understand and view the world. The first is around a cognitive shift from realist to constructivist understandings of science. And this has opened up space for that middle ground, for some skepticism around absolutist claims and an awareness of risk, uncertainty, and safety. And second, she's argued that the fragmented authority of the state has prompted us to think slightly differently about the role of democracies in responding to the needs of citizens. Her reflections resonate with my own, as I explore how lines of sovereignty are becoming even more blurred, as new technologies prompt reconfigurations of politics and call for a recalibrated understanding of citizenship, voice, and expression. So my book is built on a curiosity about these shifts. And while I don't look at Europe and the United States as Jasanoff has, I want to understand what has been happening in the global South. And I was interested to see how citizens worked across transnational networks, for example, to precipitate changes in policies that would lead to those governments introducing medicines that became vital to their capacity to live. So in these 2 areas, I look at, on the one hand, how HIV medicines are perceived and embodied by women. And I respond to that focus in the first 3 of the 5 substantial chapters that I have in my book. The rationale underpinning this facet of my work connects with Jasanoff's description of the shift away from absolutist claims and towards a recognition of uncertainty. I wanted to understand how women embody and experience medicine outside of the discourse of politics of life and away from the notion that medicines are a fix to illness. Some of the theory I've worked with include biosociality, embodiment, precarity, and feminist new materialism. Feel free to ask me more about this theory because I love talking about theory, but I'm not going to do it now. And methodologies. I've used multi-sited ethnography, participatory photography, journey maps. I'll show you some pictures, and narrative interviews. All right, and then the second main area of focus has been about how women perceive and engage with the state as citizens. And this is connected to the rationale in which we think about, or we start to recognize that the state cannot respond to all of its citizens' needs. So even when the vitality of citizens is tied to the vitality of the state itself is porous and has a limited capacity to provide the kinds of drugs like lenacapavir that citizens may need. And so here I engage with Southern theory, biopolitics, everyday citizenship, and actor network theory. My methodologies are quite similar for both. It's connected. Multi-sited ethnography, video and photography, key informant interviews, and policy analysis. Okay, and the last three substantial chapters look specifically at the politics of medicine. All right, I'm going to give you a whistle-stop tour of my three chapters, and my wife has read my many thousand words transcript and just told me it's far too long. So I'm going to trust that you ask me questions if anything is unclear. So my first chapter starts at the heart of my research, which is the women that I worked with. The women I worked with, some of them you can see on this picture taken in Hlwele, which is just in Cape Town, over here on the map. I've got this quote here from Zama. It's like when the skies fight, when the clouds are angry and dark. They crash into each other and lightning flies across the sky. You never know where the lightning is going to hit. That's what it's like with HIV. So this chapter explores the skies that fight, the proverbial lightning strikes that bring HIV, which I conceptualize as a non-human actant in actor network theory, into women's lives and into their bodies through the lens of precarity and along three interlinked pathways. I look at these pathways as HIV moves as an actant from parents to children through birth. I look at them horizontally as they move across and through sexual relationships and sex. And then I look at them in terms of diagonal pathways that transect vertical and horizontal pathways and around how people that I worked with experience the impact of HIV in their lives, in their households, and with their families. In this chapter, I make the argument that concepts like vulnerability dislocate the responsibility for addressing, for example, women's heightened susceptibility to sexual violence in South Africa from the actors that need to be taking responsibility. It's often brought down to dynamics of interpersonal inequalities, whereas in this chapter in particular, I make the case for yes, that may well be true. And we need to think about how women are working strategically as agents to challenge these unequal power dynamics. And there are a lovely set of ethnographic stories in that chapter that speak to that. And we need to think about why it took so long for South Africa to develop a national strategic plan to address gender-based violence. And that we can't be separating out these broader forms of structural violence from embodied experiences of vulnerability. They come together. And the way that I talk about them coming together is through the concept of biopolitical precarity, which you can ask me more about if you want. So in chapter 4, I look at a set of new generation struggles. And here is a body map by Bongiwe. And these photographs here are with me and Nondumiso doing some journey mapping in my flat in Cape Town, where I think Hayley has also been. And in this chapter, I shift from looking at the pathways that HIV entered women's bodies, looking at how medicine entered women's bodies. And then I said, well, look, these medicines are here. We have the world's largest antiretroviral program. What are the key struggles that these women are experiencing now in the present? And in this chapter, I look at two linked sets of narratives, and the one is about what's happening inside the body and the struggles that women are experiencing around side effects and treatment fatigue, for example, difficulties around adherence. And then I link those struggles, which I call new generation struggles, with a set of struggles about the body and context. So what it's like to live in Khayelitsha, for example, where walking to the public toilet at night without any electricity or any lighting places women at risk. What it means to be struggling to get your child into the kind of school that they need to be getting into because they have specific sets of learning differences, for example. And I talk about these emergent struggles as they happen inside the body and as they happen with the body in context as biopolitical. And I argue that by drawing biopolitics into conversation with precarity again, we start to bring state actors and international actors into focus. Why is it that in post-apartheid South Africa, we still have such high rates of violent crime, such high rates of unemployment? Okay, and then the next chapter, chapter 5, looks at health citizenship, and it says, what are people doing about these struggles? Because there's a lot that people are doing. And in order for me to get a sense of how people saw and spoke to the state, I worked with a core group of women who took photographs of places where they saw the state and places where they saw the state in its absence. So before I tell you a little bit about those photographs, I'm just going to give you a little excerpt from my book. How am I doing for time?
Carry on.
Yeah. We're waiting in a very long queue, snaking out from 3 pharmacy counters to the general waiting area of Miriam's clinic in Khayelitsha. We spent most of the time chatting to a large number of comrades, as Miriam referred to them, who came up to greet her. The stream of people passing in and out of the clinic and who joined us as we waited in the queue created an ever-shifting node of playful, often proud chatter amongst friends. This little node of friends cycled in size, growing and shrinking, as we waited in an otherwise linear queue, where solitude rather than sociality seemed to be the norm. When I commented on Miriam's social life, very active social life in the clinic, and particularly in the pharmacy queue, she smiled and said to me, Sana, which means my dear, it's because we fought for ARVs together. I take this cue as an entry point for this particular chapter, chapter 5, because it points to the way that space and sociality are produced over time through memory, and because it indicates shifts in citizenship practices as they are embodied and as they coalesce around shifting biopolitical concerns. And this chapter marks a shift from really fine-grained ethnographic work around embodiment towards looking at how people are engaging with the state as citizens. Are they conceptualizing the role of the democratic government in their lives through their ability to access medicine, and then also through the importance of being able to access safe toilets, safe electricity, safe water, employment. So although I reflect on medical anthropological conceptions of governmentality and citizenship, particularly therapeutic citizenship, my fieldwork emphasized the importance of understanding everyday citizenship as it's lived and embodied. In their research on citizenship in Indonesia, Berenschot and Van Klinken argue that people's experience of citizenship in post-colonial states is not only dependent on the formulation and implementation of formal laws and regulations, but strongly shaped by the strength of their social relationships. They call for a rethinking of normative theories of citizenship and foreground scholarship from the global south that details how in post-colonial contexts like India, South Africa, Indonesia, informal networks enable citizens to navigate interactions with state institutions. Reflecting the scholarship that calls for more nuanced understandings of particular contexts or states of citizenship as they unfold across time, this chapter engages with the visual methods of my fieldwork to explore how people saw and spoke to the state through the lens of their cameras. And this set of photographs was taken by Sibongile, and I felt like it spoke quite strongly. They're actually not in my book, but I discussed them in my book. they speak quite strongly to the presence of the state as well as its absence. So in Sibongili's neighborhood in Khayelitsha, there was no collection of rubbish. So every Saturday they would burn all their rubbish together, and this is the rubbish pile over here. Here's Sibongili's children. But this Saturday, President Zuma was coming to visit. So they weren't going to burn the rubbish because that would sully the very slick presentations and preparations that were happening around our President Zuma's visit. So here you then see the rubbish, and you see everybody gathering for President Zuma, who then in the next photograph is arriving up on stage. And then the final photograph of the day is of the fire, burning all the rubbish, of citizens taking it into their own hands to manage a problem like the state not collecting waste. All right, so I'll move on from looking at how South Africans are thinking about and engaging with the state through different citizen practices to moving over to Brazil, to seeing how people are thinking about and talking to the state also through different citizen practices. And I was interested and curious to understand more about Brazil because through the work of the Treatment Action Campaign, South Africans often looked to Brazil as a country that had effectively responded to the need for antiretrovirals right at the beginning. In 1997, it was the first country in the Global South to provide these essential medicines to people. And so Brazil and South Africa started off with HIV infection rates at around the same level, and they were predicted to rise in the same way. Brazil's now has a 0.4% prevalence rate. South Africa's prevalence, does anyone want to guess? I mean, it has been up to 25. It's 17.6% at the moment. So I was really interested to understand how these two trajectories had unfolded, what was going on in these two different countries. And in order to be really brief, I learned through my colleagues, like Solange, for example, with whom I worked in Brazil for many years, and with her colleague at the University of Pernambuco, Ana Vieira, that it is problematic to construct Brazil as an activist state. That through the fieldwork that I did in Brazil, I realized, in fact, there has been a massive push towards neoliberalism and marketization, and that has strongly impacted the health system. So here, Dr. Mendes, for example, says there are 3 doctors here and we need to attend to 1,200 people per month. It's just too much for us. The government doesn't value our work anymore. It's not like the old days. What I noticed in Brazil is that it was struggling with balancing neoliberal reform with its constitutional commitment to its citizens. And that had a real impact on how people navigated and advocated for medicines. And so we have what João Biel talks about as the judicialization of the right to health, where people use the courts in order to compel the government to provide the newest technologies that would have fewer side effects. And what I was also struck by is that the struggles that the people I've been working with in South Africa were having around side effects and adherence and treatment fatigue were very similar to the kinds of struggles that people were having in Brazil. So there were some quite interesting similarities across the two countries that had I not gone and done fieldwork there, had Hayley not encouraged me to go and do fieldwork there, I wouldn't have figured that out. And the final substantive chapter moves out in scale. So we've got the first 2 chapters looking at South Africa, then I move on to look at Brazil, and the final chapter says, right, so we've got these democratic states. Now they are both providing antiretrovirals, but we have a whole set of international instruments that are limiting their capacity to actually meet the needs of their citizens. And in this chapter, which is a lot drier than the previous chapters, it doesn't have all the kind of very lovely ethnography in it, was much really. I really get into the nitty-gritty and the nuts and bolts of how intellectual property rights work. I look at the history of the TRIPS agreement, the Trade-Related Intellectual Property Rights Agreement, the role that South Africa played in compelling the World Trade Organization to introduce a set of flexibilities through the Doha Agreement. I then outline a whole set of the ways that patents block countries from accessing newer medicines like lenacapavir. I've listed them there. And then I look at some of the mechanisms that we have in place for TRIPS flexibilities that can ensure governments are able to compel pharmaceutical companies to make generic forms of their medicines available. But what I speak to quite strongly in that chapter is the role that India has played. India has become known as the pharmacy of the global south. It produces up to 85% of the world's medicines, of generic medicines. But I also look at how its pharmaceutical industry has been strongly threatened by free trade agreements currently under discussion with the European Union that are telling the Indian government to contain and restrain the power of its pharmaceutical industry in order to enter into this FTA. And that means not producing generic medicines and not using the kinds of flexibilities that have been available. So I move right out in scale and I look at some of these international actors that continue to place pressure on these democracies like India, like South Africa, like Brazil, and impact the capacity of those countries to meet the needs of their citizens. Okay, I think I'm good. I probably have finished. Thank you very much. Happy to take questions.
Lots of content.
Yeah.
So let's get on with our discussants. And Nondumiso, are you ready to put the camera on and give us your reflections on your journey as an activist and an artist and your long collaboration with Beth? Can you hear me?
Yeah, I can hear you.
Wonderful. We've got you up on the screen, so you're very clear. Thank
All
you.
right, that's good.
You go
Okay.
ahead.
All right. Good evening, everyone. I'll be reading from what I've written. I don't have a slide or a presentation that is going to pop up. Okay, so as you know, my name is Nondumiso, and I'm one of the women who is a member of the Bambanani Women's Group, which is the women living with HIV. So I've been working with Beth for a very long time. I've even forgotten how many years it is and when we met, but I know where we met. So we met at the AIDS and Society Research at the University of Cape Town. At the time, I think she was still a young student and also was the acting director of the AIDS and Society Research at the time when I met her. So I've been involved with her, I've been working with her in different research projects that she has been doing, and including her PhD thesis. And I've been working alongside her as a research assistant, helping her run the interviews with the closest speaking women and then translating those interviews for her. So this journey with Beth, it gathered and it shaped a beautiful friendship that we have. So now I'm going to talk about my journey as an artist and activist. And it all started at the University of Cape Town with the AIDS and Society Research Unit. So around 2000. So it was a program, they created a program within the center, which was designed during the time of HIV and AIDS pandemic. And they used at first memory boxes and books. So the memory box and books, the intention was to leave a legacy for your family or your friends, or if you had children, you leave something of yourself, because at that time, life-saving medication were not available. However, later on, it changed due to the efforts of treatment action campaign and the efforts of the local government at that time, who allowed medicine sans frontières to pilot the antiretroviral treatment. So at the same time, the government was not allowing these life-saving medications to people who were living with HIV at that time, because not understanding the virus, the link between the AIDS and the virus and the human system, how they link and how it can make you have AIDS and how the antiretrovirals can assist you in terms of getting your health back. So it changed to another form of artwork that was introduced by the AIDS and Society Research Unit under the supervision of Unnithan Morgan at that time, and other researchers at that time as well. And we worked with Jane Solomon, who was the core designer of the body mapping process, which we worked closely with her and closely with Unnithan Morgan, who was also I'd been the director of the unit at that time in 2002. So we worked closely with them and researchers alongside. And it was a wonderful process where initially first it was more about now there's this action that needs to be taken, this voice that needs to be heard, this message that needs to be given to the government that we were having at that time, which is during the Thabo Mbeki governing. So it was a struggle, a very huge struggle, a very serious struggle, which is within our body maps that we created. Just a brief to tell you a bit about the body mapping is you trace around about you trace around your body outline, and then it gives a life-size image of yourself. So where you speak about how the HIV is affecting you psychologically, physically, mentally, socially, and also politically. And at that time, we were receiving medicines, but we're not under the government. So we were voicing out the effect of the medication in our bodies. It was just at the beginning of getting that medication into our system. And I remember I was only 3 months in the medication, and it was working beautifully. So the purpose of this now was to speak out and say, these medicines that are not being allowed for many South Africans who were suffering at that time to receive life-saving medication so that life can still make sense again, working. And they were making a big impact in people's lives. And we are one of those people, numbers of those people that we're using at that time to show that it's working for us. And the government therefore should allow the medication to be brought to South Africa and be given to the people who are in need. So also the body maps were also addressing the stigma at that time, which was so much of it at that time, to address the stigma that we have experienced in communities, our family members, friends, in relationships, first with ourselves, trying to understand what is going on and how and when, what happened, why we're here. So there were a lot of things happening at that time. So these artworks were shown in different exhibitions across South Africa, across outside South Africa. I remember my first trip was in United States, in New York. So that was the first exhibition that I went to, and others were in South Africa, trying to pass on the message, trying to say to the government, understand this is happening, and then we need this medication, and also inviting international people to support these medicines for South Africa. Also, Um, hmm. Okay. So I can say that in South Africa, we have used different mediums of art. There were so many activists. We had the vocal ones, which was Treatment Action Campaign, which was very powerful in their activism. And we had different kinds of artists saying their voices for the government to be able to say yes to these life-saving medications that the South Africans needed. And so many were dying each day. At that time, there were more than 5 million people dying. I mean, living with HIV, and 600 a day were dying. And it made a lot of impact it felt like even though we were separate in this activism, but we had the same goal and had the same vision. And it was like a collaboration of being activists. You have those running in the streets, shouting with so much passion that this needs to happen, this needs to take place. The government will have to hear the voices of those who need, who stays in poor communities who cannot afford these life-saving medications. And then we have those in closed doors, speaking on radios and so on, and using art to speak, to voice out the need for this medication. It was a tough time, but we managed, all of us in this collaboration, to get the government to bring in the medication to South Africa. Working with Beth has been, I don't know how to explain it in English. I think it has been a blessing working with Beth. I've learned so much from her, and I've learned so much about me, and I've learned so much about my community, the world, and through my travels and through these exhibitions and what it means to be part of something important. So for me, that has been my journey. And it's been a wonderful journey that I've traveled so far. I can also say some of the work that I've done with Beth again, most recently, after COVID, still within COVID, I helped her with some research around gender, COVID, and HIV, and concerns about social and economic factors affecting us during that time of COVID, and being a woman and living with HIV, and then it's COVID around. So it's been a wonderful experience. Yeah, I think, I don't know. I think I'm done with my presentation at the moment.
That's wonderful. Thank you.
Thank you very much.
It's a privilege to hear that account from you, that story. So thank you very much.
I'm gone. It's fine to close it.
Wow. Maya's going to take us into another space. So we have this really diverse set of voices coming in to discuss Beth's book. So they're the story of art and activism, and Maya's going to take us now to her work on reproductive justice in India. Why don't you come and sit again, facing the audience?
Thanks very much, Beth, for having me here and giving me the honor of responding to your wonderful work. I think I'm going to just offer some reflections, essentially from what I've understood from what you've done and how I've known you since 2016. And I think the connection is really around, I think, body maps in some ways, because I'm thinking about, and that connects with what Nondumiso says, And it connects also with the kind of ways in which I think our common research in medical anthropology tries to communicate experiences that people have of, of their conditions. And then how should these then translate into convincing policymakers to actually make access to medication? And I think you have done that so well in your work, and you have taught us also a lot about body maps and I remember you sending me, that was, I think, the first interaction was this kit about body maps and how to, how to actually do the things. So so thank you for that. So in terms of, I think one of the important things, I guess, about body maps is visualizing and spatializing the disease or the illness. It's about, and I think this actually goes back to something, maybe, I don't know, I've just remembered. And by the way, this is all off the cuff. So, I might make a few mistakes here, but I've actually remembered how, Foucault, way back when he talks about the history of the development of medicine, talks about that very fact when we kind of open up the body, when we have those techniques and technologies that cut open the brain, for instance, and we actually visualize, the internal organs, and we spatialize disease and illness in that process. We can see where this disease. And so that led this whole development of medicine as we know it. But what we are seeing here in the body maps that women themselves are producing is a very different kind of knowledge that comes to this kind of spatialization of medicine and illness, which then, we need to, and that's why I think it's so fantastic. I think that arts and visual aspects to, particularly to medicine, and bringing people's experiences are really significant. And in fact, you do one more thing here, and I think that what you do is link this to women's activism in order to access HIV medicine. So again, the book is centrally, as you said, about two aspects. One is activism, and it really makes you think about, and made me, what you were saying, think about, well, what defines this activism? What are these different kinds of activism that exist around disease, health, and illness? And I'm thinking about, some of the work that I've done in India on sexual and reproductive health activists, and how, who these are, and whether the activists are the people who suffer themselves, what kind of activism then is connected with that, versus people who represent others in their activism. So you have health activists who are doing a whole set of sort of things, and often sexual and reproductive health activists are people who kind of, that's not the only thing they look at, but it's part of a whole set of things. And then there are other things I've been involved with, like, children who suffer from thalassemia. And it's their parents then who become the most important activists in sort of mobilizing funds for. So again, thinking about activists, what actually is effective activism? Who are those people who can really mobilize, the state in that sense? I think that, and how they are actually so dynamic in heralding change. This happens in South Africa, India, and Brazil. And yet in all these places, you have very different forms of activism that take place. And again, your book is an example of how that activism actually, happens. Then I think so you bring these three countries then into dialogue with one another in a kind of specific way to foreground two things. One is the scale, as you say, through which policy functions. And then on the other hand, and the way activism operates to impact, who can or who cannot access affordable HIV sort of treatment. So I think that is something, quite new in some ways, that how you're bringing these three countries together, but in slightly different ways. And I think the link between probably South Africa and Brazil is more talked about in your book. I think the fact that India did lots of work on generic medicines with CIPLA, particularly with HIV, etc., was really foundational in the early part of the rise of access to medicine. But again, what's the where is it now? And you do mention some figures in the book about people living with HIV in India, but I don't trust the figures. We we don't really know. And it depends on the state's also approach to these issues, whether, they are collecting what is the broader politics there in terms of what does it mean to say we have so many people living with HIV in our country and not? And, obviously there's also the whole thing in South Africa as well with Mbeki and about recognizing that, so there's that broader politics, which is so important to keep in mind. So I'll just pick on a couple of things which I think you do really nicely in the book. And I think one thing, going back to the issue of so it's women and the state, and going back to the issue of the people living with HIV. And I think that there is one really important point you make here, and that is that everybody has the right to what you call a non-projected future. And I think that's such an important point. That is, when we think about people who suffer with really debilitating conditions, we always kind of foreclose hope. Hope is not there. So, but we need to approach it differently. And we need to approach it in terms of, yes, living with uncertainty. But at the same time, that, living with uncertainty and in this kind of non-projected future, thinking about, not projecting in a particular way, we can actually open up to unexpected potential. And I think that's a lovely thing. And I kind of see that more in terms of what I'd call, I know you say not hope, but I'd call it sort of fragile hope. Yeah. And I think that is important to recognize and to keep with us. And for the women themselves, for everyone, I think the other thing that you do really interestingly here is talk about, we all talk about agency. Yes, so, are we victims? How much can we change the world in which we live? And I think that what you say about the agency in terms of that space between structures that both act down and agents that act up. So here, again, a very nice way of, thinking about how, so what does this mean? That is, women actively, like Nondumiso, etc., are, acting up on the implications of HIV in their lives. And they enjoy politically a role as activists. And this is really sort of important because within that, then they are at the same time embodiments of the ways in which HIV medicine has been acting in their body. So they're doing that, but they're also at the same time, they're using and they're navigating constantly. I think, as you say, the ways in which one should balance the desire to have a sexual relationship with the risk of knowing what that brings. So this is again the kind of work that women are, are doing on the ground. Then just two other points. I don't know if do I have some more minutes? Okay. So then I think the other thing that you bring up, which I think is also really useful, which is thinking about what does it mean to focus on the epidemiological, as opposed to, say, the social or the relational, the emotional. And my sense is that, and I think this is really true, is that focusing on the epidemiological leads to a kind of victimization, and in this discourse on HIV, it's about women as victims and men as perpetrators. But that then erases the state and these broader structures and the accountability, So again, one has to be careful about this broader narrative. And here, actually, I'm also reminded of some of the work that I've been doing in India on sort of just thinking about reproductive health and how that is very differently configured by the state, which uses a public health stroke epidemiological kind of way of thinking about reproductive health in terms of, say, reproductive tract infections, and reproductive health is being able to be safe from these reproductive tract infections. But actually, people on the ground don't see it in that way at all. They see it, more in terms of being free, being able to carry out social relations in a particular way, being able to enter the temple, being able to be ritually pure, for instance. It's a very different way of conceptualizing this, and that then brings a very different way of thinking about access to care, for example. And I think that, but in that case, of course, there's a complication, because when you focus on who focuses on these different perceptions, and what is the role of medicine or in well-being in these kind of contexts. Okay, and I think, another thing that you do, and again, this is in no order, is focusing on what I call you call non-human actants. That is the actual medicine, as things in themselves, and the way in which, in a way, and this showcases complexities, both in terms of the way different kinds of medication are acting on the body, and how this, and you've traced historically how this then has moved the whole HIV, sort of living with HIV discourse amongst people who live with HIV, from, not just access to medication, but also things like how do you deal with viral resistance? How do you deal with side effects? And how do you deal with treatment fatigue? The fact that you have to constantly, so it's shifting here, and it's nicely kind of linked with the history of what you're saying. I think I'm going to stop there, but just some sort of insights that hope will draw you to the book. So thank you.
Lovely, thank you. Wonderful. Well, last but certainly not least, we're going to go to Lenore, and wonderful. Gary, can we? Great. Excellent. Thank you, Lenore. You're on the big screen now. Do go ahead.
With a halo. I'm going to read this and again, and although Beth has given a wonderful overview, I'm actually going to go back to the content of the book. But firstly, I'm so pleased to be here and be able to speak. So recently, I was working with Susan Levine, who Beth thanks in the book, and who was a colleague of hers. And I had reason, and then Susan did, to reread a novel that, when it was published, was especially provocative. And that was John le Carré's The Constant Gardener. For those of you who don't know it, it's a book of intrigue, greed, and foolhardy bravery, personal, national, and international networks, corporations and the state, laboratories and populations, privilege, precarity, and extreme poverty. It's the kind of book that fiction writers write because they can. They may, faithfully or loosely, draw on fact, but the genre allows them to step beyond this. It is wonderful, given this, to be part of a gathering to celebrate a book that equally unfolds and reveals, that is generous in scope, and which brings together rigorous research and detail, theoretical sophistication, powerful analysis, and compelling writing, and also, like Le Carre, is on drugs. In HIV gender, not that I think, Beth, you will necessarily end up being at the airports as everyone's must read, but one can only hope. In HIV gender and the politics of medicine, Beth Mills provides us with lessons that bury into and stretch beyond the book's core themes of HIV, globalization, and the body. An obvious one is this: it is possible to write a grand account that draws on 20 years of research, that sets the histories and politics of HIV care in 3 countries and continents in global context, and in its storytelling moves from a virus to a multilateral organisation. It is possible to maintain the seamlessness of storytelling that keeps these themes resonating and articulating without losing the core human stories of the women whose lives set the tone at the outset. Another, it is possible to bring together very diverse theorists, Foucault, Latour, Weber, Abudure, theorists advocating for and from the global south, analyses of intersectionality, and to ensure coherence, while nevertheless focusing on the lives lived and lost in challenges to access life-saving treatment. Another, it is possible to write such a wide account and not trivialize the issues through generalization. HIV, gender, and the politics of medicine is deeply scholarly, based on rich ethnography, wide reading, and solid analysis. But while it is possible, it is surely not easy to have done all of this, and the task of doing so must have been daunting. It is great testament to Beth Mills' scholarship and your fortitude, Beth. Not that you pulled this off, that would underestimate your work, but that you wrote such a compelling, thoughtful account, one that showcases careful scholarship combined with a deep and a generous understanding of the people involved as you unravel the contradictions and complexities of the political history of HIV. I want to briefly reflect on South Africa's and other countries' experience of HIV in the early years and bring this to the present. It's an arc following Beth's. It's a story we worldwide know well. The first case of illness in the country is diagnosed in 1982. The numbers at the outset are relatively low. The caseload begins to increase and to shift from men who have sex with men to women, and increasingly to younger women. Antiretrovirals offer hope from 1987, and as Beth shows, the provision of and access to antiretrovirals rolls out in Brazil soon after, but not in South Africa. There, HIV was ignored in the volatile and tense years leading to independence. Then treatment was ignored as democratic governance was put in place, and the need to provide appropriate care for the health and lives of what seemed to be so few was swept aside in the excitement of a new South Africa. Then Thabo Mbeki's administration. For 9 years, the president and his key political staff did nothing. In many tellings of this period, Mbeki is a buffoon, playing a card of folk epidemiology and folk therapy at the expense of the lives of some, in the end, 1/3 of a million South Africans. His health minister advocated traditional medicine and a diet of beetroot, garlic, lemon, and sweet potato rather than ARVs. Yet one point was made at the time, reiterated in a global context in 2008 when Mbeki stood down, and is finally documented in this book. The social determinants and commercial determinants of health are no less responsible than the virus itself for the fatal spread of infection and explain poor access to treatment and early death. In 2023, and now, as Beth reminds us, South Africa has the the world's largest HIV epidemic in terms of prevalence and absolute numbers, with an estimated 7.8 million people living with HIV, around 13% of the population or more. HIV still impacts on men in early middle age, but more so on young women, particularly in their very late teens and their early 20s, and so it also remains a risk for infants. South Africa has been enormously successful globally in its program for the prevention of mother-to-child transmission. The tragedy is that this intervention will continue to be needed. So too will continued ARV treatment for neonates, children, their parents, and others. And in some cases, the infant deaths that Beth describes, sparely but no less painfully, will continue to occur now as 25 years ago. Historically, deaths from HIV in South Africa and continued transmission were largely the result of a decade without essential medication. South Africa now claims phenomenally high coverage of ARV medication and manages well the need to shift around treatments in the context of drug resistance and unpleasant side effects. But still, healthcare is often delivered by unkind and unsympathetic and no doubt overworked staff, and adherence to medication is troubled by treatment fatigue, viral resistance, continued stigma, and depression. Further, political, economic, and social factors continue to contribute to the transmission of HIV as a cause of a cause. Mbeki was no fool, and 20 years on, as Beth illustrates with powerful granularity, the social and political economics of the distribution of disease persist. The people most likely to be infected now, as then, are poor. South Africa's inequality gap is one of the highest in the world, with over 50% of the population estimated to live below the poverty line. Most of those infected who struggled with medication and the challenges of living with HIV are concentrated here still. Early in the book, Beth highlights the everydayness of poverty, the backdrop to people as they remember to take medicines with or without food, to step over live electricity lines, and, as Beth has mentioned today, to use unlit toilets and risk rape. It is magnified for people with HIV who should be or are on treatment when some medicines need to be refrigerated, but not all people have money for or access to power. Everyday encroachments on how life is lived, the absence of a fridge, the risk of rape, the lack of food, Beth describes as biopolitical precarity. And pharmaceutical companies thrive on the profit they make from misery and poverty. Beetroot and garlic would not have made a difference, but differences in the distribution of wealth, education, employment, opportunity, and the fair delivery of health care may have made a massive difference then, and they would now. We the world, face a dilemma of the intransigence of inequality and poverty, and of other social problems which these provoke: food insecurity, housing insecurity, gender-based violence. Hence the attraction of a deft program that allows health providers to change medications as needed, and for those medications to be available freely. Even here, political and economic inequalities between states, not households, perpetuate unequal health outcomes. HIV treatments in the public health system in South Africa and elsewhere, including Brazil, may be older and therefore more affordable, but with more side effects than newer medicines, influencing adherence. There's another point I want to make to add to others' thoughtful remarks. In March 2020, I was on radio in South Africa, and the anchor person compared the great influenza pandemic of 1918 to 1920 with the unfolding COVID-19 pandemic. The flu pandemic was, he said, the last pandemic we'd had. Somehow, just like that, the HIV pandemic, still escalating, still leaking the health budget, had been rendered invisible. Many of today's scholars working on HIV are too young to remember the shocking early days of the pandemic, by which I mean the HIV pandemic. HIV, Gender and the Politics of Medicine is essential reading of the history of its first 2 decades. For those concerned with the lived experience of HIV over time, the book is indispensable. For those interested in the social life of medicine, this is the book. The story she tells provides a magnifying glass on policy and ethics, a prism to explore intersectionality. Books like HIV, Gender and the Politics of Medicine are critical to keep the challenges of HIV prevention, transmission and treatment in mind, to remain mindful of how human rights are imbricated with responses to the virus, and to maintain watch on how global economic and political networks maintain regimes of inequality. HIV, Gender and the Politics of Medicine guides us to think about this complexity, and Beth makes an incredibly important contribution to scholarship and politics for this reason. Beth, congratulations and thank you.
Thank you so much, Lenore, and thank you for bringing us right back to that really salient issue of health inequalities and these multiple intersecting crises and pandemics. Thank you. And I sort of feel we need to pause a little bit because those of us who work in medical anthropology, one feels and always has to give a sort of trigger warning for the subject matter. But we have 20 minutes and it would be wonderful to have questions, and we also have no questions yet, just lots of congratulations, Beth, which you can see later.
Sit down at the table.
Yeah,
Yeah,
I think we can sit down here. Gary suggested was in the front row. Yes, great. We have Gary has a microphone, so if anybody has a comment or question, let me know.
Hi. With your comparisons that you made between Brazil and Indonesia specifically, how do you feel that the Eurocentricity of the global pharmaceutical and medical world has negatively impacted the potential for treatment, specifically HIV treatment, in those countries and potentially any other countries?
That's a great question. Should we take a few? Or should we take
It is on. I don't want to bring too many because it's sometimes starting session. So why don't you go with that, and then maybe we can it links to quite nicely to the North's final point.
Yeah.
Pharma vested interests, qualities of power.
I mean, it's been quite an undertaking for me to get my head around the insidious ways that pharmaceutical companies work to limit countries and their own pharmaceutical industries. South Africa has pretty good pharmaceutical industry, so does Brazil, you may know this. And, you know, in my final chapter, I outline some of the ways that it does that through, for example, evergreening practices. So dolutegravir, I may be mispronouncing it, is a gold standard treatment for HIV. And there are over 20 variations that have been created for this particular medicine that have enabled the pharmaceutical company that produces this medicine to continue issuing new patents, which means it continues pricing those medicines out of reach of countries in the global. So, you know, there's a great deal of evidence to show that pharmaceutical companies have a number of different strategic approaches to pricing medicines out of reach of most of the world. And we are constrained, people wanting to challenge those companies are constrained because of the power of the World Trade Organization's intellectual property rights regime.
Wonderful. Is that a hand there? No. No.
Your own reflections, your own work.
I'm going to read you some, Beth, because actually there's some really nice comments that sort of underscore Lenore's points. This book is very necessary in the South-South context. Interesting point, which in its differences continues to be a challenging context in terms of social determinants, patriarchal, racist, homophobic. And I guess also this, this point, South Africa and Brazil, both countries with massive inequalities, and India as well. I really liked the way Lenore brought us back to that. And then here also, conflicting political agendas. I'm particularly drawn to the complexities of women and girls in sexual reproductive health, and through how through embodiment they are equally creating their own sense of agency. And it's good to see activists at the forefront. So really linking to what Maya was saying and these different activist strategies that sort of lift out also that affective and relational element, such as through the body maps. Yeah, there we go, another point.
So did you consider, like now that the ARVs are a bit more accessible, like the future with aging with HIV, and then whether like comorbidities and especially menopause and that impact, what that will have on adherence to these drugs later?
That's a really great question. I would love to understand a bit more of your background and thinking about the link between menopause and different comorbidities. I don't have an answer to your question. I guess my book considers aging insofar as many of the women I've worked with for over 20 years. And so I've kind of journeyed with them as they have aged. But I would say that what does happen, there are different regimes of HIV medicines. And so for many of the women I've worked with, they started on first-line treatment and then sometimes developed resistance to that treatment. And they needed to move on to a second-line treatment. And when I start my book with a story of receiving a phone call after having had a meeting with MSF from one of the people I'd been working with, Miriam, who said, Sissy, what's the story? Am I going to be able to get second-line treatment for myself and my daughter? Because she was developing resistance to first-line treatment. And at that point in South Africa's history, we didn't have second-line treatment available. And so that was really compelling for me to look into why that was the case. Why is it that you're born in South Africa without money to pay privately for this medicine? You are facing imminent death if you develop resistance to medicines. That is fundamentally, ethically wrong. So yeah, that kind of story has certainly unfolded, and it's definitely something that age interlinks with and intersects with. Thanks.
Maybe, we have another question. Sophie, go for it.
Hi, thank you, Beth. That was such an interesting talk, and I can't wait to read the book. But I was wondering, in terms of the body mapping, I'm wondering about the mechanisms you use to turn those very personal and individual stories and experiences into policy, and how do you make sure that things aren't lost, and how are women's voices actually then presented into political change?
I mean, that might be a question for Nondumiso as a body mapping artist. I can respond to a little bit of that in terms of policy work. I have worked in different spaces, as a researcher, as an activist, and also in policy spaces across the last 20 years. I write about that in the book, so I didn't really talk about it today. And it was through working across those different spaces that I was able to bring some of those stories into policymaking spaces. So one of the places that I worked when I was the Deputy Director of the AIDS and Society Research Unit was I convened a policy advisory board for the Deputy Minister of Health, which led to, in conjunction with a lot of different organizations, including the AIDS Law Project and Treatment Action Campaign, a very radical and new strategic plan governing HIV and AIDS and other STIs. And wherever I could in those different spaces, and I've worked in different spaces at a national level and also internationally, I bring these stories forward rather shamelessly. I think that the stories matter, and I've often been pushed back and for data, for quantifying my kind of the narratives that come through in my research, and I've had that experience here at IDS, and it's okay. We can do that. We can quantify stories strategically, but those are some of the ways that I have brought those stories into policymaking spaces, unevenly, imperfectly, for sure, but I've tried.
It links to Maya's reflection, really. I think we had a question somewhere in this table. No? No. Oh yeah. Okay, go for it. Yeah.
Hi, everyone. Hi, Beth. Thank you for the book. I came precisely because I'm from South Africa, and I just wanted to kind of hear from, someone who then steps outside of the country quite often, how that looks, because it's something else when you look at it from the inside. And I wanted to understand, and this question can be or to Nondumiso or Lenore to actually think about, what are the specific things that you feel that the government can do, to try and improve the situation? Because yes, the literacy has done a lot in bringing about awareness, but as you said, the stats are still quite high, and it almost feels as if the country has reached a point of stagnation almost, when it comes to responding to the virus. So I wanted to ask, what has come out of your research that you think people, especially the women that are affected by the disease, feel like it could be done to actually alleviate the situation?
So I have two responses, but I think let's start with Nondumiso and Lenore and see what their reflections are, and then I can share mine. They want.
Nondumiso, did you hear that? It might have been hard to hear, or Lenore. There was a question, actually, it's probably a good one for you, Nondumiso. Did you hear a sort of question about what could be done to sort of shift? Sorry, what is your name? Nonkuleko was asking what can be done to shift the current sort of stalemate, and as she sees it in the sort of prevalence of HIV in South Africa. What would be the current sort of ask of the government? What could be done?
Well, then it goes back to, do we have the money to do that? Because for me, I feel like what happened during the time of, I'll say during our time when Action Campaign was there, Medicine Sans Frontiers was there was more information that was given to people. There was information every day. You will learn about so many things, side effects, stigma, how to take care of yourself, basically. So now all of that has been a shutdown. And then you find that there's still more HIV infection and more, what can I say this in English now, sorry, interventions. But then my wish is education at the clinics still to go on, at schools, all the places that were happening during that time, the awareness should still go on. But then the problem is there money to do so? Yeah.
Yeah, I hear you. I think Yerke, and then we'll go there, and then we have two questions online. Maybe we'll take these two together.
Okay, thank you. So I'm Jörg Redstrom, working here at IDS. I used to work on HIV, actually, with Hayley, and we've had many conversations. Thank you, Beth. I really look forward to reading this book. And just it's triggered by some other questions, in particular around the coloniality of the pharma industry, but I'm actually thinking about the second word in the title, HIV and gender in politics, and the second and third, gender and politics, in relation to the HIV pandemic and response. Because my question is about in development, international development broadly writ, and in the development sector's response to HIV, gender has always been very instrumentalized, I'd say. And for me, a big problem with the framings and the kind of, it's not just medical framings, but it's development discourse framings of gender as very stereotypically heteronormative, household-based, women and men, and women are vulnerable, men are, you know, predators, all that, which of course defies the realities of spread, HIV spread, and so on. And having been sort of witnessing the response since the 80s myself, and what struck me about HIV activism has very much been, you know, coming from the left side and challenging our understandings of gender and politics, and in some ways, so just to get around to the kind of the question, well, trying to formulate the question, because today we're seeing very strong pushback against women's rights, LGBTQI rights, minority rights, sex workers' rights, and some of those latter groups are actually the groups who were very active in the AIDS response, HIV response, politicizing and mobilizing and challenging the international community. Whereas women's organizations writ large were not so active earlier on, but are now becoming more active. So I'd love to hear you reflect a bit more on the role of gender and politics in this, possibly in relation to that. I mean, it's a very difficult question because sort of the colonial question about our framings are very Eurocentric. Yes, they are, but they are also that in development. Sorry, I'll stop there.
Hi, so I'm Lindsay. I'm a colleague of Beth's in Anthropology and International Development. Thank you, Beth. I'm very excited to read your book. It's sort of a reflection, maybe more than a question. I guess as someone who works on a different issue, gender-based violence, but related issue that also affects everyone in the world, but particularly affects people in the global south. And again, where there's been a kind of takeover in terms of the way that gender-based violence is understood and viewed by fairly northern-dominated approaches, by certain disciplines. So in the mainstream spaces, it's public health. It's a model of risk factors that cause gender-based violence and how the consequences are modeled. And it just resonates so much because when I work a lot in Africa, as you know, as well, and a bit in Asia, you know, it just totally takes away from how people experience, how people embody the social dimensions of gender-based violence and what people's own priorities are. So very much I've come across so many situations where with this kind of global north point of view, what we measure, how we measure, the priority, for example, is put on physical and sexual forms of violence, which of course we need to address. But so many women have talked to me about economic forms of violence, emotional forms of violence, and that just gets completely sort of silenced. So it's really a comment just to sort of see those parallels really, and I'm about to start a new research project in Tanzania with Tanzanian colleagues, and using also fairly creative methods, participatory methods, and really thinking about what we want to influence the policy space. So it's very similar to you. How do you use those methods, which are much more about people's stories, people's experiences, the meaning that gender-based violence has in their lives and how they articulate that, and how we kind of start to use that to influence. Because I'm not going to the conference in Cape Town next week on sexual violence, because I'm a bit fed up with it as well, because it's just lots and lots of North Americans giving randomized controlled trials results with tokenistic global South colleagues. You know, so there's this whole politics of that space as well. So it's not really a question, you might want to respond to it, but it's just an observation and I'm so glad that you've been able to do this with the book, and I'm excited to read it just to see how you've done that, because I will sit in those spaces, but I want to bring these other forms of knowledge into those spaces as a ways of understanding and then affecting what we address and how we address it, because it also feeds into programming, it feeds into policies as well. And we miss so many things and so much is missed. Thank you.
They're really, really lovely comments. Thank you. Thank you, both of you. I mean, what I'm hearing across both of your comments is the power of northern framings that are of both what gender means and what gender means in relation to HIV and what gender means in relation to sexual violence. and the dominance of those framings being very difficult to challenge and very difficult to shake up. I think that is why we do the work we do, is to be pushing back. And there is no easy way to do it. I think that this is for me why I find anthropology really powerful, because it brings stories forward, and it says, in the way that Nondumiso spoke about with the body maps, it makes visible quite private hidden experiences of having a virus inside your body that's creating all kinds of illnesses without treatment, or hidden experiences of different forms of violence that are economic or psychological, and that may not be visible necessarily. And it does seem to me, you know, having engaged, for example, around the development of the SDGs when I was here at IDS, that there is kind of a limited bandwidth of these international policymakers to take those stories into account. But I haven't let that stop me, and I don't know if those policymakers are going to read my book. I would love that to happen. But I do think that what I have learned, and Maya, you mentioned this in your remarks as well, is that what I have tried to do is reflect what I saw, which is for sure that gender is not about a binary of male and female. It's for sure not about women in households per se. It's for sure not about women in heterosexual relationships. It's far more complex than that. And what I found too, in speaking to that complexity, was this framing that women are subjects to different forms of violence, often framed in policy terms as being interpersonal, is highly problematic. And I make a very, very strong, very strident argument to the way that that framing, that violence happens between two people, or that HIV happens between two people, is totally dislocating and removing from responsibility the policymakers at a national level and at an international level. And we need to constantly be pushing back and calling those people, they are people, they're sitting in boardrooms and they're drawing up the free trade agreements that are governing how India is going to be able to use its pharmaceutical industry to continue to provide antiretrovirals to the world. Those people need to be held accountable. It does feel a little bit like, I can understand why you're not going to that conference, and it's frustrating when there's such a powerful and dominant narrative. But I think that's the beauty of the work that happens in IDS and the work that happens in Sussex, that we are challenging those norms. And I mean, the Backlash program, Yoko, that you've been a part of, is very much, as I understand, doing the work of saying we need to be paying attention here.
I'm going to amalgamate some online questions as the final question, and I want to try and link it to what you've just been saying, so I don't want to lose this sense of the activist. But several people are interested in your own journey theoretically and how that shifted, and quite an interesting question here as well. So have you stayed in one theoretical home, and how did you navigate changing theory? You can see, and also I think quite an interesting question here was a higher up about this point of HIV, of the medicines, the social life of medicines, the medicines as actors, I think was the question. So yeah, and also the actor network theory. So maybe if you could answer that in a way to sort of close up, but linking also to your journey, because you bring together, as Lenore said, this sort of beautifully, the arts, the activism, and the sort of critical analysis. So briefly tell us that journey.
So let me try. I appreciate you all staying on a bit later.
Yeah, and then we'll have to close, I think.
Thank you for those questions, and so wonderful to see some of you there. Wesley, I saw your point about sending the book to policymakers. Yeah, I'll do that. My theoretical journey has looked very different in 2003 when I first started working with Hlwele, which is a home-based care organization. The Treatment Action Campaign said we need more information about how home-based care organizations are managing the high levels of death. And I did fieldwork. That was my first fieldwork, and I talk about that in the book with Hlwele. And then I worked with Fiona Ross, my supervisor, and I remember Fiona starting to introduce me to some questions about why do we think the state is responsible for providing these medicines, which led me into thinking a little bit more about what has been written And so I kind of moved into understanding a bit more about Foucault's theorization around medicine, around biopolitics, around governmentality. And then with time, and as I continue doing my fieldwork, I realized some of the limits of Foucault's theorizing. You know, he talks about how governments work at the level of the individual and at the level of the population, so anatomy politics and biopolitics, but doesn't really talk about this continuum across the two. And I have wanted to think about that space in between a lot more. And that has required me to use different kinds of theories in the way that Lenore quite beautifully put. I had a little cry, Lenore. I mean, I've had a little cry all the way through today. It was so beautiful to hear your reflections. Thank you. And thank you, Nondumiso and Maya. Because I had to constantly be working to find a theory that could help me understand what it was that I was doing. And the theories, the more I did my research, the more I realized some of those theories which are largely developed in the North. So, you know, theories by Butler around precarity, for example, and theories around governmentality by Foucault didn't really fit with the work that I was doing. And so I had to kind of bend my thinking a little bit more. And I found actor network theory really helpful as a tool for starting to unpack how bodies and governments are porous and we're all fundamentally connected. And then recently, I've become a lot more aware of feminist new materialism as a theory that's, or kind of a set of theoretical approaches that has been developed by people in the Global South and by indigenous scholars in North America to say, let us understand how we are connected to the fish and to the water and to the air that we breathe and to the medicines that we eat. We need to understand all of these intersections together, and it's possible to create a robust theoretical piece that speaks to those intersections in a way that also holds people who have power and organizations that have power accountable. So that's a summary.
Brilliantly done, and what a wonderful way to end. So thank you everybody for coming. I'm sure Beth will hang around if you want to congratulate her import person, but thank you. That is wonderful. Thank you all for your contributions. Thank you also to everyone online. We'll pass on very interesting comments, and thank you, Lenore, and thank you, Nondumiso. Thank you. Bye.